Hello, this is John Kanellopoulos here from our office in Athens, Greece, the Laser Vision Ambulatory Surgery Center. We're seeing here a 44-year-old gentleman who 20 years ago, 2000 for the right eye, 2001 for the left eye, underwent a cornea transplant for keratoconus. And this is him evaluated about 6 months ago. We're seeing the right eye graft that looks relatively good, left eye graft. So we're okay with that. The problem is that although the cell counts are relatively good, remember that these are 20-year-old grafts, and all cell counts are over 500 and relatively similar. We passed the major problem. The issue here is that we have a lot of astigmatism in the right eye. 9.2 Diopters measured on the pentacam. But the key thing here, the caveat here, is that this astigmatism is mainly bulging at the graft-host interface. Remember, the pentacam gives us a 9mm diameter view of the cornea. The graft is about 8 usually. And the left eye has a different picture, has regular central astigmatism of 9.3 Diopters. So we have within the same patient two different manifestations of post-PK astigmatism. We know automatically that the patient is an eye rubber. And what this has caused in the right eye, and we're seeing some nice OCT images here with the Avanti OCT device, that the graft-host interface, this is the 5 o'clock position of the right eye, has started to stretch out from the eye rubbing. And this is what is causing the ectasia at that point. We're gonna see some more sections. This is the 6 o'clock position. Again, you can see how this area, the graft, centrally, the host peripherally. We can see the host was thin to begin with because obviously this was a keratoconic eye and it was thinner inferiorly than the host that was used. You can also in this picture see the suture track of the original procedure. This is 20 years ago. Amazing technology, still keeps us amazed. Again, that right eye, this is the 6:30 to 7 o'clock position. And the reason I'm showing all this is that once we see a patient like this, our treatment strategy changes, because here it really doesn't make sense to do a laser procedure and treat. As you can see here, we're seeing the thinning of the graft-host interface here under 480 microns, and it's going to be very thin here. The central cornea is relatively good. We saw the cell count is good. So here we're going to use the technique that we've described in many meetings, and it is on our YouTube channel, to re-gut the incision 360 degrees, soak the interface, not a total freeing up of the transplant, but go as deep as possible, almost down to dehiscence membrane with a 15-degree knife manually, and then soak that interface with riboflavin, resutured with interrupted sutures, degraft, and then perform an annular flash cross-linking session. And this, in essence, is our treatment to reduce this graft-host interface dehiscence that is mainly in this area here. Now, we talked about a little bit about the left eye. Left eye is a different picture. We don't have an area that's ectatic. The inferior cornea is not necessarily ectatic. The pachymetries confirm this. The cornea is nice and thick all the way around the graft-host interface. We just have significant regular astigmatism. It's 9.3 Diopters, is quite a bit. So the strategy here would be a laser procedure. We're going to jump to our surgical day. So we have two different procedures to deal with. We're going to perform a PRK procedure in the left eye. Obviously, no laser can approach the 9 Diopters of treatment. So we're going to use two separate treatments. One would be a myopic astigmatic treatment, and one would be a hyperopic astigmatic treatment, in order with two treatment cards treat the total of 9 Diopters of myopia. And on the other eye, as I mentioned, this is the surgical report. We will re-gut the incision 360 degrees, place 6 interrupted sutures, soak with riboflavin solution, and then perform cross-linking. And we're going to see some of the intra-op images of our procedure here. Here we're seeing the cross-linking after the right cornea has been resutured. And we can kind of see in this picture the sutures. We can see the hyperfluorescence in the graft-host interface from the riboflavin, and this is Vibix Extra by Avidro, and now glucose. So it's a 2.5% riboflavin solution, and we're treating 7.2 joules for a total of 4 minutes in order to re-strengthen the cornea at that area. And these are images for that from that same day. This is the eye at the end of the procedure. Try and get a little better focus here. And we can see how we've resutured 360 degrees. This is the our OR, use a surgical microscope, and then the KXL1 device to perform the flash cross-linking treatment. Our laser treatment, we're moving now into our laser room. For the other eye was one session with, as I mentioned before, a hyperopic astigmatic procedure. So a +1.5, -6 at 37 degrees, followed by a second session of a +0.5, -3 at 37 degrees in order to be able, with 2 different cards, treat the total amount of the very high astigmatism over 8 Diopters. And let's jump now to 6 months later. This is our exam performed yesterday. And this is the right eye, resutured. Our best corrected here is 20/30. And this is the left eye. We mentioned that this was treated initially in 2001 with a transplant, and our PRK double card treatment was 6 months ago. And this eye is now an astounding 20/20 minus. So very good approximation of the metropia here. We're gonna go and look, which I find always very impressive and dramatic. A lot of pictures here. We'll try and see. Yesterday, we removed some sutures from the 10 o'clock position seen here and the 5 o'clock position. And this is what we got as post-op topography. And if I go and look at the total pre-op to post-op change, we will have this as a summary of where we started with this patient. And remember the remarkable amount of ectasia here and astigmatism. We resutured the graft, placed 16 interrupted sutures. This is after removing 6 sutures at 6 months post-op, and we're almost astigmatically nil. This is a very, very rewarding picture for a cornea surgeon to see. And I add that we used that same graft from 20 years ago. We didn't do a regraft on this patient. This is the images of the left eye that underwent the double card PRK procedure to reduce the astigmatism, and we can also see how impressive the difference is in this map as well. This was our pre-op for the left eye. This was an interim topography, and the one from yesterday showing the remarkable correction of this very high astigmatism, and how specific with the X500 excimer laser and rotation adjustment is the correction of this very high astigmatism in a post-cornea transplantation patient. So, in summary, and now close with going back to those dehisced areas and how now they have been resutured and they've been brought back together. This is, of course, the 3 o'clock position. That's not that critical, but if I look here, I can see how this area has been approximated. Again, same images of that same area. We'll look at the superior cornea resutured here, and we're gonna try and find, this is the 9 o'clock position again, graft-host interface, and how with the resuturing, we have a better approximation of the graft. This is the left eye that undergone PRK, and this is the right eye. I'm sorry, this is the left eye again. And we'll go and look at some images from the right eye, 9 o'clock position, and the most critical in the right eye, 6 o'clock position. You can see how after resuturing the graft-host interface, I have a better approximation, and we've reversed this stretching of the interface and the cross-linking. You can see it as hyperreflectivity, and the graft-host interface is able to stabilize that result. I know this is a very laborious description, but at the end of the day, with a -7 soft contact lens, this eye is 20/25, and this eye is uncorrected 20/25 plus. We have a very happy post-cornea transplantation patient, and corneas that have been 20 years out and still working very well for the patient. I hope you found this interesting. This is John Kanellopoulos signing out from our center here in Athens, Greece. Thanks so much for your attention.